The next speaker is Dr. Kailash Kurdia from All India Institute of Medical Sciences. Kailash, I think while DG is such a oral feeding is such a controversial topic, one of the areas where we have very good quality evidence and which has definitely made a big difference in management of pancreatic cancer is how you define borderline pancreatic cancers and the role of neoadjuvant therapy, which has led to improved outcomes. So I'd like request Dr. Kailash Kurdia to take over.
So while Kailash is speaking, I need to inform all the students that Kailash did a very beautiful review on various definitions of borderline resectable pancreatic cancer. And after he finishes, I'll project a slide that how you can get that review from us. So students, please send me a mail, vkkapoor.india@gmail.com. Write BRPC in the subject of the mail, and I will be happy to send you the soft copy of the review which Kailash has done with me on BRPC. So students, please note this number. You can send a WhatsApp message to Dr. Anand Nagar to join Jaipur surgical tutorial, and then you will get information about all the online sessions, including the master classes. All these videos have been uploaded by the IT team of Avinash Tak in Dwarika Clinic, Ahmedabad. They offer all the technical support.
I am presenting here borderline resectable pancreatic cancer and neoadjuvant chemotherapy. But my presentation is a generic. It not only stick to the neoadjuvant chemotherapy, it may also include neoadjuvant chemoradiotherapy and some anatomical and staging part. So according to location, the head tumor is located to the right side of the left ward of the superior mesenteric vein, and the body tumor in between the this superior mesenteric vein and the right to the aorta, and left tail tumor is located to the left of the aorta. And so the staging is includes T1 tumor is less than 2 centimeter, and T2 tumor is between 2 to 4 centimeter. T4 tumor is more than T3 tumor is more than 4 centimeter, but it is not involving the arterial vasculature, and if it is involved arterial vasculature, then it is the T4 tumor. So since NCCN first described the borderline resectable pancreatic cancer, the definition mainly based on the anatomic criteria, and more specifically on the extent of venous and arterial involvement by the tumor. So anatomical definition of BRPC is a tumor that is high risk for margin positive resection when surgery is used as initial treatment strategy. And margin resection is important in ensuring the best prognosis. So there are multiple definition of borderline pancreatic cancer is available, but kindly move to next. There is an international consensus given for the borderline pancreatic cancer, which is so borderline subclassified according to SMA portal involvement alone or arterial invasion. So SMA portal vein involvement alone is the if tumor contact 180 or greater, or bilateral narrowing or occlusion of the SMA portal vein, which is not exceeding the inferior border of the duodenum, and also there is no tumor contact or invasion to SMA, celiac axis or common hepatic artery. Or in case of arterial involvement, SMA celiac axis tumor contact of less than 180 without showing deformity or stenosis, or CHA, in case of CHA, tumor contact without showing tumor contact of the proper hepatic artery and or celiac. So this is the diagram is as Dr. Utpal already said how to assess the jejunal vein. So it is very difficult to assess the jejunal on radiography. So to see the relation of the tumor to the duodenal, it can easy to the whether it is the involvement of jejunal vein is there or not, because it is one of the important factors by which you can decide whether you are able to reconstruction or not. So again, depending on the which type of portal vein involvement, it also associated with prognosis. As in we saw in if a type A just there is abatement, then the prognosis better than the type B, which is just unilateral involvement, and in type C there is bilateral narrowing of the portal vein SME, and in case of type D, if it complete occlusion which is displayed by the collateral, then the prognosis is further worsening. So now coming, what are the various prognostic factors associated with the pancreatic tumor? So despite recent advance in multidisciplinary treatment approach, still relapse rate are as high as 70% within 2 years. And the risk of tumor recurrence depend on various factors. One is the unique and aggressive biology of pancreatic cancer, and various pathological characteristics such as lymphovascular and perineural invasion, nodal metastasis, positive resection margin. So the after implementation of standardized protocol for pathologic workup, which rapidly increased the number of reported R1 rate from 20% to 80%. So as after the standard protocol, and if the tumor is located in the uncinate, especially in the uncinate part, and if you see the arterial vasculature is located here, so there is on proper slicing of the specimen, exact resection margin can be told whether it is R0, R1 or R2 resection. So there are survival data following for curvature and non-curvature surgical resection for curative and non-curative surgical resection for pancreatic cancer. As we saw, if there is a R1 resection is there is a median survival was significantly lower than the if the patient achieve the R0 resection, which ranging from 12 months to more than 55 months, but in R1 or R2 resection, it's ranging between 6 to 22 months. So, coming to the BRPC and neoadjuvant chemotherapy or neoadjuvant treatment. So, over last decade, several studies on this topic have been published. However, debate about the best management for pancreatic borderline resected pancreatic ductal adenocarcinoma still remain open. Since the available literature does not provide high level evidence, most of the studies that advocate neoadjuvant treatment are because of non-randomized trial with selection bias by reporting survival after resection rather than by intention to treat analysis. Moreover, due to extreme heterogeneity of the definition of borderline resected pancreatic cancer adopted by published study, the interpretation and comparison of the result are very difficult. So, what are the advantages of neoadjuvant treatment? It leads to early systematic treatment for undetected micrometastasis, as well as increase of R0 resection rate and reduction in term of post-operative pancreatic fistula. But it also associated with some disadvantage like reduction of chance of surgery due to disease progression during the treatment, and also so the literature show limited significant down staging. But currently, the NCCN guideline recommend the neoadjuvant chemo or neoadjuvant treatment in of borderline resectable pancreatic cancer rather than upfront surgery. So this is the one of the first randomized trial which published in 2018 to assess the benefit of neoadjuvant chemoradiation with gemcitabine versus upfront surgery in patients with borderline resectable pancreatic cancer. So this was a phase 2-3 trial. In this total 110 patients designed to enroll with borderline pancreatic cancer, and the gemcitabine based chemotherapy neoadjuvant chemoradiation treatment with 54 gray EBRT followed by surgery, or upfront surgery followed by chemoradiation treatment for large volume center was done in Korea. And the primary endpoint was 2-year survival rate, and the interim analysis was planned at the time of 50% case enrolled. So in both groups, the tumor characteristics are comparable, including tumor size of 3.4 and 3.5, as well as clinical T stage, N stage. Always, though there is a difference, but no clinical significant difference in the clinical N stage. as well as location of the tumor and vessels involvement. The results showing after excluding the patient who withdrew consent, total 58 patients enrolled and 27 patients were allocated to neoadjuvant treatment and 23 to upfront surgery group. The overall 2-year survival was 34% with a median survival of 16 months, and intention to treat analysis showing a 2-year survival and median survival in a neoadjuvant treatment group is 40.7% and median survival is 21 months. In comparison to the upfront surgery group, we saw the 2-year survival is 26.1% and median survival was 12 months. And also the higher R0 resection rate in the neoadjuvant treatment group, which is 51%, and in upfront surgery group around 26.1%. And also pathological finding and tumor response of patient undergoing surgery in the showing that there is significant decrease in the tumor size also present, as well as patient having around 10% of the patient having complete response in the neoadjuvant treatment group, and there is a significant increase in the R0 resection rate. Rest of the parameter is comparable. So again, this curve showing according to intention to treat analysis, there is significant survival advantage seen in the case of neoadjuvant treatment group than the upfront surgery group. However, the per protocol analysis showing there is no difference in the survival group. So looking to the recurrence pattern after neoadjuvant treatment and upfront surgery, there is no significant difference in the both groups. So overall recurrence in the neoadjuvant treatment group is around seen in 88% and also in the similar to the upfront surgery. And interestingly, the loco-regional recurrence rate, even the higher rate of R1 resection, it is also comparable in the both group, neoadjuvant as well as the upfront surgery group. So this is another randomized trial of in which they compare the chemoradiotherapy versus immediate surgery for resectable and borderline resectable pancreatic groups. In this patient, they also include the both resectable as well as borderline group. This was a in the neoadjuvant adjuvant treatment. They include the preoperative CTRT arm, which include the 3 course of gemcitabine, and second cycle combined with 15.2 gray of 15 cycle of 2 gray each radiotherapy, and followed by surgery, and followed by 4 course of adjuvant gemcitabine in the neoadjuvant group, while in the immediate surgery group, patient underwent upfront surgery, and which was followed by 6 course of adjuvant gemcitabine chemotherapy. And primary endpoint was overall survival by intention to treat analysis. Total 240 patients randomly assigned, in 190 in the neoadjuvant and 127 in the immediate surgery group. The median overall survival was 16 months versus 14 months, which is not, there is no significant difference. However, the resection rate was also there is no significant difference. The R0 resection was significantly higher in the neoadjuvant treatment group. So neoadjuvant treatment was associated with significantly better disease-free survival and local regional failure-free survival. Also showing a significantly lower rate of pathological lymph node, perineural and venous invasion. And survival analysis of patients who received adjuvant chemotherapy saw improved survival in neoadjuvant treatment group, which is 35.2 versus 19.81. It means those patients after neoadjuvant chemotherapy and surgery and then again receive the adjuvant treatment, they have significantly higher survival rate. So this is the table which is showing the baseline patient and tumor correction by treatment regimen. In this table, we saw that borderline resectable pancreatic cancer was in preoperative CTRT around 45%, and in immediate surgery was it was around 47. percent. And the mean CA99 level was higher in the immediate surgery group, but which was not a significant, statistically significant. And these curve are showing there is a period operative chemo radiotherapy in comparison to immediate. There is no significant difference in oral survival. However, there is the patients on disease-free survival, loco-regional failure free survival, as well as distant metastasis free survival. So these disease-free survival and loco-regional failure-free survival is significantly higher in those patients underwent preoperative chemoradiotherapy. But there is no difference in the distant metastasis free interval. So again, intention to treat analyze of primary and secondary endpoint for both subgroup of patients with resectable and borderline solving. In this patient, the in case of borderline resectable pancreatic cancer, which include 113 patients, the resection rate was though low in the preoperative chemoradiotherapy group, but R0 resection is significantly higher. And again, the survival curve is showing. In case of borderline resectable, it is preoperative chemoradiotherapy group have significantly better overall survival, as well as disease-free survival and loco-regional failure-free survival. This is one more randomized control. This is the long-term outcome of this same trial, which at the median follow-up 59 months. So overall survival was better in neoadjuvant group than the upfront surgery group, although the difference in the median survival was only 1.4 months. The 5-year overall survival rate was 20.5% in the neoadjuvant treatment group, then compared to the 6.5% in with upfront surgery group patient. So this is the recently published another trial, randomized control trial of aspect 5, which include the divide the patient in forearm immediate surgery, then short course neoadjuvant gemcitabine plus capecitabine, another regimen is FOLFIRINOX, and fourth arm is the chemoradiotherapy in patient with borderline resectable pancreatic cancer. So it was a multi-centric open-label randomized control trial done in the UK and Germany. The treatment group, as I already mentioned, there are 4 groups. So post-neoadjuvant treatment, patient underwent restaging CT scan after 4 to 6 weeks of neoadjuvant treatment, and underwent surgical exploration if the tumor was still at least borderline resectable. All patients who had their tumor resected received adjuvant therapy at oncologist discussion, and primary endpoint was recruitment rate and resection rate. Analysis were done on intention to treat basis. So total 478 patients was screened, and finally 90 patients was randomized. Rest of the patient excluded for various reasons. And 33 patients allocated to emergency surgery, 20 allocated to neoadjuvant gemcitabine and capecitabine, and 20 patients to FOLFIRINOX, and rest of the 17 patients allocated to chemoradiotherapy group. The result was showing the slow, but 40 patients out of 55, which is around 80%, completed neoadjuvant therapy, and 6 of these patients had partial response, and 21 of 31 patients in immediate surgery, and 30 of 55 patients in the combined neoadjuvant therapy group underwent resection. The outcome show immediate surgery group versus neoadjuvant therapy group. The R0 resection was in 14% patient versus in 23% of patient in the combined, including all modality of neoadjuvant treatment. And median follow-up time was 12.2 months. On that, the 1-year overall survival was 39% in the upfront surgery group versus 78% in the for gemcitabine plus capecitabine group, and 84% for FOLFIRINOX group. And however, in case in chemoradiotherapy group, it was only 60%. Again, the 1-year disease-free survival was lower in the upfront surgery, which is only 33% in comparison to 59% for combined neoadjuvant therapy. 3 patients reported local disease recurrence, 2 in the immediate surgery group and 1 in FOLFIRINOX group. So, in conclusion, short course neoadjuvant treatment had significant survival benefit compared to immediate surgery group. And neoadjuvant chemotherapy with either gemcitabine plus capecitabine or FOLFIRINOX had the better survival compared with immediate surgery group. Now, there are multiple meta-analysis which comparing upfront surgery with neoadjuvant treatment in patients with resectable or borderline pancreatic cancer. This is the one of the first meta in which the total 38 studies are included of 3,484 patients, of whom 1,738 patients had neoadjuvant treatment group, around 50%. The median overall survival by intention to treat was 18.8 months for neoadjuvant treatment and 14.8 months for the upfront surgery. The difference was larger among patients whose tumor was resected, which is 26.1% versus 15.0. Sorry, 26.1 versus 15.01 ratio. The overall resection rate was lower with the neoadjuvant treatment than with upfront surgery, but the R0 resection was higher in the neoadjuvant treatment group than the upfront surgery group, which is around in neoadjuvant treatment 86% and in the upfront surgery around 67%. So reported by intention to treat, the R0 resection rate were 58% and 54% respectively. And the pathological lymph node rate was 43% after neoadjuvant therapy and 64.8% in the upfront surgery group. So, neoadjuvant treatment appeared to improve overall survival by intention to treat, despite lower overall resection rate for resectable or borderline resectable pancreatic cancer. This is another systematic review and meta-analysis. We saw oncological benefit of neoadjuvant treatment versus upfront surgery in borderline resectable pancreatic cancer. This is especially in borderline pancreatic cancer. In this, they compared the survival between BRPC patients who underwent neoadjuvant treatment and those who underwent upfront surgery. The overall survival was compared using intention to treat analysis. Total 1,204 publications were identified and 19 publications with 21 data set, including 2,906 patients in the neoadjuvant treatment group and 1,560 patients in upfront surgery were analyzed. 2 randomized controlled trial and 2 prospective studies were included in this meta-analysis. 13 studies performed an intention to treat analysis, while 6 presented the data of resected patients. The neoadjuvant treatment group had significantly better overall survival than upfront surgery group in the intention to treat analysis and resected patient. So among the resected patient, the R0 resection and node negativity rate were significantly higher in the neoadjuvant treatment group. And neoadjuvant treatment improved the overall survival, R0 resection rate and node negativity rate compared with upfront surgery group. This is another meta-analysis which showing the neoadjuvant therapy for or upfront surgery for resectable and borderline pancreatic cancer. There are 7 trials with 938 patients were included. All trials included a neoadjuvant gemcitabine-based chemo or chemoradiotherapy arm. None of the studies used adjuvant FOLFIRINOX. Neoadjuvant therapy improved overall survival and compared with the upfront surgery. And this represents an increase in the median overall survival from 19 to 29 months. And in subgroup of resectable pancreatic cancer, no statistical significant difference in overall survival was observed. In the subgroup of borderline resectable pancreatic cancer, neoadjuvant therapy improved overall survival. So, with this, they concluded neoadjuvant therapy improved overall survival compared with upfront surgery in patients with borderline resectable pancreatic cancer. So, these are the multiple studies in which the borderline resectable these 2 studies have included the isolated borderline pancreatic resectable group. So outcome with neoadjuvant therapy or upfront surgery. So the oral results is showing the resection rate is lower in the neoadjuvant treatment. However, the R0 resection rate is significantly higher, as well as pathological N0 stage is significantly higher in the neoadjuvant treatment group, and there is no significant difference in the major complication group. And the grade of summary of these finding for median oral survival in neoadjuvant therapy, it was 29 months. Then, in compared to the 19 months for upfront surgery, which is the grade of evidence is high. For resection, it is around 80 to 100% in the upfront surgery group, and neoadjuvant again that is 75 to 100%, and the grade of evidence is moderate. For again N0 resection or major surgical complication, the so for N0 resection it is moderate, and for major surgical complication the grade of evidence is low. So again, outcome of primary chemotherapy for borderline resectable and locally advanced pancreatic ductal carcinoma. So this was the objective of this study was to investigate pragmatically the treatment compliance, conversion to surgery, survival outcome of patient with borderline resectable and locally advanced pancreatic cancer. And this prospective study took place in National Reference Center for Pancreatic Disease in Italy. Consecutive patient with borderline resectable and locally advanced pancreatic ductal carcinoma were enrolled at the time of diagnosis. The result showing around 60% of the patient have borderline resectable pancreatic cancer, and around 10% of the patient lost to follow-up, and 92% of the patient receive chemotherapy. The chemotherapy regimen most used FOLFIRINOX and gemcitabine plus nab-paclitaxel. In this study, 19 patients receiving chemotherapy died within 6 months, mainly for disease progression, and the treatment completion rate was around 70%. The oral resection for oral rate of resection was around 15.1%, and in borderline resectable case, it is around 24%. In case of locally advanced, it was only 9%. The independent predictor of resection were include the age, borderline resectable disease, chemotherapy completion, radiological response, and biochemical response. The median survival for whole cohort was 12.8 months. Factor independently associated survival were again completion of chemotherapy, receipt of complementary radiotherapy, and resection. In patients who underwent resection, the median survival was 35.4 months for initially borderline resectable patient, and 41.8 months for initially locally advanced patient. So this is the recent meta-analysis published recently, which comparing the upfront surgery and neoadjuvant therapy in the both resectable and borderline resectable pancreatic cancer. So study comparing neoadjuvant therapy with the upfront surgery in resectable and borderline resectable pancreatic cancer. Primary endpoint was overall survival. Total 10,000 studies were identified, and the meta-analysis finally enrolled 50 revealed studies. And the meta-analysis suggests that neoadjuvant therapy significantly improved the overall survival as well as recurrence-free survival. Furthermore, neoadjuvant therapy lead to favorable post-operative outcome with an enhanced R0 resection rate, reduced lymph node metastasis, and perineural invasion, although it is associated with reduced resection rate. In addition, patients treated with the neoadjuvant therapy experience superior survival benefit compared to those undergoing adjuvant therapy. And neoadjuvant therapy has the potential to provide survival benefit and improve post-operative long-term outcome for patients with resectable and borderline resectable pancreatic cancer. However, to validate and reinforce these findings, further well-designed and large trials are required. So, in conclusion, around 30% of the patients present either borderline resectable or locally advanced, and due to architectural feature of borderline resectable pancreatic cancer, as these are located near to the vessels, especially the tumor is located in the uncinate, upfront surgery result in higher R1 resection rate. So neoadjuvant treatment could degrade the stage and improve the R0 resection rate. In addition to controlling local disease, it also assesses the biology of tumor. So in summary, neoadjuvant treatment is primarily used to select suitable surgery candidate and improve the tolerance of preoperative treatment. The superiority of neoadjuvant chemotherapy and neoadjuvant chemoradiotherapy for borderline pancreatic cancer remain unclear, and there is still controversy about the most appropriate neoadjuvant treatment regimen. However, NCCN guidelines recommend FOLFIRINOX or modified FOLFIRINOX plus minus radiation, or gemcitabine or capcitabine should be the used as a neoadjuvant in treatment for in case of borderline resectable uh, cancer as a first line regimen with or without radiation therapy. Thank you.
Yes, Kailash, I think, yeah, a very thorough presentation. One thing you clearly established is that definitely borderline resectable pancreatic tumors, neoadjuvant it's now a dictum. But in terms of neoadjuvant chemotherapy versus radiotherapy, I mean, is it, am I to understand that there's only one study in that area, the SPAC 5, and in that, I didn't understand the conclusions. Did they conclude that the FOLFIRINOX and paclitaxel, that group only, the gemcitabine, those groups only provided survival advantage? Because in the conclusion, you didn't mention that there was no survival advantage of the radiotherapy group. And that's one question. And the other thing I wanted to ask you is, am I to understand that after neoadjuvant chemoradiotherapy, the only non-progression is the only criteria which you said to how do you select patients for surgery, or is there any other things which have been reported in literature, like how much percentage the CA99 should come down or anything like that?
So actually, regarding first question, in aspect trial, the maximum benefit was seen in those patients who received the FOLFIRINOX or gemcitabine nab-paclitaxel. Though in the chemoradiotherapy group, there is increased survival in comparison to upfront surgery, but it is less than the the group of modified FOLFIRINOX as well as gemcitabine or nab-paclitaxel.
So as of now, it's either equal or possibly superior. Is that the conclusion? Chemotherapy to radiotherapy. As of now, there's no non-inferiority. It's not inferior to radiotherapy. Is that what you can say?
Yes, sir. This is no. There is no conclusive whether it is radiotherapy or neoadjuvant. Only chemotherapy. There is no conclusive evidence to which is the better, whether it is superior or which is inferior. There is no such conclusion can be made by available literature.
There is very little evidence to compare chemotherapy versus chemoradiotherapy.
Yes.
But most of the centers do not favor radiotherapy due to some technical issues for arterial reconstructions or venous reconstructions. Most of the high volume centers, either Del Chiaro group or Heckert group or the Buchler group, all are not giving radiotherapy. They are basically preferred neoadjuvant chemotherapy specifically for the patient where they are planning for arterial or venous resection.
That is the reason
in India also, it's almost all groups.
Compare.
So what was your second question, sir?
No, the second question was like, in one of the last trials, you said only 15% became resectable after borderline resectable. So is non-progression the only criteria to take them up for surgery? If there's non-progression, take them up for surgery, or they use the other criteria that CA99 should be come down by 50%, or any such.
That is the only anatomical criteria, whether it is stable disease or maybe partial response or complete response. But that is the criteria.
I mean, I think basically I think after neoadjuvant chemotherapy, you really don't need, you can't assess if it's a partial response or a complete response. The response is difficult to assess on imaging. And the only criteria is there's non-progression, you're happy enough to go ahead and take them up for surgery.
Yes, sir.
Thank you.
So, though there is a biological criteria is seems to be more practical, but till date, most of the literature is follow only the anatomical criteria for assessment of the response assessment as well as the resectability.
I would like to thank all the three speakers and Phani for moderating, and Dr. T.D. Yadav and Ashwini and Harjeet for attending. And thanks to Dwarika Clinic team for technical support. See you in the last week of August for the next masterclass. Thank you, everyone.
Thank you, sir. Thank you.
Thank you, sir.